Hello everyone, and warm welcome to you once again. We are in our 7th experience sharing session, and today is the 29th of March, 2022. If we are here, it is for the first exercise of Full Learning Cycle 1 of the Movement for Immunization Agenda 2030, and that exercise is situation analysis. And just a reminder of the calendar for situation analysis, the timeline. We are actually in week 2, and this week you are expected to submit the initial version of your situation analysis on peer grade on or before 11:59 p.m. Friday, the 1st of April 2022, and 11:59 p.m. is actually Geneva time. So the key resources, the instructions, what you need to do as far as the situation analysis is concerned. The first thing is you have to join peer grade. So, and for others that are like Lucinda, that are just joining today or are trying to catch up, the easiest way for you to do so, I'm just going to share you the link. If you have not yet joined peer grade is a platform where you need to submit your situation analysis and also do peer review. So it's indispensable for you if you are going to make it through the full this exercise on situation analysis. And I'm sharing the link with you in the chat. There is a short video tutorial. If you watch this tutorial, you should be able to join a peer grade and submit your situation analysis when the time comes. You don't need to finish writing the situation analysis before joining peer grade. Please do so as soon as possible, because the deadline to join peer grade was actually last Friday. But you still have the possibility. We are giving you the exceptional possibility to be able to do so now. And the next thing I want to talk about is the 2 key documents that you need to use to guide your situation analysis. And those documents are the rubric, that is what we call the rubric. Is like a guidance document that specifies a series of criteria that you need to follow to develop a good situation analysis. And we have the model, the template, that is a Word document. It's on which you're going to type your situation analysis. And for you to download those 2 documents, I'm sharing the link with you in the chat. You can click on that link to download these 2 documents, which are essential for you to develop your situation analysis. Now, I have a question for you to get a pulse. I want to get the pulse of the group that is gathered here today. And my question to you is, have you completed and submitted your situation analysis in peer grade? If you have done so, can you type yes in the chat like I have just done? If you have not done so, please feel free to type no in the chat. So I see yes from Amsalo Shifiro, yes from Professor Becky Takbo. I see no from Adesoji, yes from Lucy Palmer. I see yes from Abdullahi Jallo. So a good number of yeses. If your response is no problem. No problem. You still have 3 days. You still have 3 days before submitting the deadline is actually Friday. So you have the 3 days to submit your situation analysis in peer grade. So today, let me just lower the hand that is raised. So I'm going to be inviting you today. If you answered yes to my question, and you want to share your situation analysis, I'm encouraging you right now to raise your hand so that you can share your situation analysis with peers that are in the room. If you're able to share your screen, it's even better. That way you will share your screen and actually put up your situation analysis on the screen so that we will be able to see what you put in the situation analysis. And Dr. François Gasse, who is our guide on the side, will be able to ask you questions as well as the peers that are here will ask you questions that will help you to elaborate more on the situation analysis. So before I invite Joshua Ienomi to take the floor to present his situation analysis, I'd like to invite Dr. François Gasse. When we talk about situation analysis, what is it about? What do at least participants in this exercise expected to put into their situation analysis? Warm welcome to you, François, and over to you.
Thank you, Charlotte, and hello again to everybody that's present. Happy to be here with you and to learn of your situation analysis as you've been guided to do. I think what's important in the situation analysis is to be as specific as you can. And when you have developed a challenge and you need to describe that challenge, which is in fact something that prevents you to achieve your overall objectives, that could be a coverage, that could be a dropout reduction, that could be a zero dose reduction. You need to describe exactly the challenge you want to address that you believe is preventing you to achieve your objective. To be specific, a challenge needs to be very well described briefly. Who is concerned? How big is the problem? How many people are of concern? What's the weight of the problem towards your goal? Where is the problem located? What size of population is concerned? And in a way, why it's important for the area where you work. And of course, the next step becomes to analyze the reasons for the challenge. If you know it, you may have some information coming from different sources, but you have to ask your questions in order to be able at one point to understand the root cause of your problem and to develop corrective measures that are likely to help you to do better. So what's important is really to understand the problem and the cause of the problem. And of course, you may need other steps to get all the information that's necessary to get you to understand the root cause. Sometimes without an interview of people concerned, you may assume that some strategy of communication would work, but if you know really the reasons why some people are refusing, then you know what to say and what to do about those refusals and address them to convince people otherwise. So thank you, and looking for you to your experience. I'm looking forward to hear from you. Thank you. The challenge and difficulty in writing your challenge.
Thank you very much. Thank you very much, François. I'm actually asking Joshua Naomi, if you're able to unmute yourself. Your hand is raised. So hi, Joshua, please start by introducing yourself and tell me, are you able to share your screen?
No. Hello, everybody. I'm Joshua Naomi, joining from Nigeria. I'm unable to share my screen at the moment.
Okay, so I can go ahead and put up your situation analysis for you on the screen, if that's okay by you.
Yeah.
Okay. All right. So that is it. I'm just going to so over to you, Joshua Naomi. You have the floor. I'm going to zoom in so that we can see more clearly. Just give me a few moments, please. Oh, there's somebody that's doing annotations. Let me just activate that. And Joshua, please, you can go ahead and start introducing yourself while I am putting it up on the screen, if that's okay.
All right. Thank you very much for giving me the floor. My name is Joshua Naomi. I'm a state technical assistant supporting COVID-19 vaccination in the Federal Capital Territory of Nigeria. So basically, my challenge is on documentation of AEFI, adverse events following immunization, COVID-19 related vaccination. So for Nigeria and for FCT, we started our COVID-19 vaccination. We introduced COVID-19 vaccine sometime last year, March last year, specifically on the 15th of March 2021. And we phased it, phase 1, targeting health workers, phase 2, targeting frontline workers, phase 3, and the likes. But as we speak now, I will say we have done with our phase 1, our phase 2, our phase 3. We are about entering our phase 4, which is looking at every eligible person in FCT, any person from 18 years and above. And like we all know, AEFI surveillance, adverse events following immunization surveillance, is one key component of immunization. Because like you can hear before now, people have been saying they are not coming for COVID-19 vaccination based on rumors, at times they might, and based on what we have done, studies carried out in FCT, we observed that some persons are actually scared of the safety of the vaccine. So for us as a state, if we really want to say, yeah, this vaccine is safe, we know that we need to take up our vaccination and our AEFI surveillance very strongly, because it is with that AEFI surveillance, what we've documented, what we've been able to track, monitor, that will be able to tell the masses that, yes, these vaccines are actually safe, or no, this portion of persons can actually come down with 1, 2, or 3 reactions after the vaccination. But to the greatest surprise, since March till date, we have observed that based on the reporting from the different area councils, we have 6 area councils in FCT, that what they report, they submit to the disease surveillance officer at the state level, and the report they submit to the data person from the primary health care board responsible for routine immunization is entirely different thing. When you compare these 2 data sets, you will see that what we have from the daily COVID-19 vaccination data is far higher than what we are having from the disease surveillance unit. So it became a concern. Late last year, November, we have to call everybody involved, all the stakeholders, routine immunization officers, routine immunization desk officers, local government disease surveillance officers, partners, and the state to sit and agree on what can be done. So we now initiated what we call data harmonization. But to our greatest surprise, after that meeting, we've held 2 more meetings this year. Those issues are still arising. And for me, I see it is a major challenge. It's a piece of concern that we need to address. So based on that, I have put up this piece to see what can be done. Please, can you help me go to?
Okay, so is that okay?
Yeah, what are the key findings? Like I've said earlier, we have discrepancy in the number of reported AEFIs, LGA level AEFI surveillance actors, DSNOs, like I've mentioned earlier, readers and the likes. They are not harmonizing their data, because for you to say, okay, this data is coming from this area council, for example, Abaji, or this data is coming from Nigeria, I should be able to say any person sending out data as regards AEFI should have the same figures. But you'll be surprised that what the DSNO sends to the state disease surveillance officer is different from what the routine immunization officer or the routine immunization desk officer sends to the state SIU. So this is actually a challenge. They are supposed to harmonize their data at that level before sending it out to the state level. Then we equally have partners supporting us. For example, the last time IHBN showed their data on AEFI, it was entirely different from what we had at the state level. Another thing we observe is that not all reported AEFIs, because for you to say this is a case of AEFI, it must have an EPID number. But we observe that when we carried our data to that, some of the reported AEFIs on the line list does not have EPID numbers. And in as much as they don't have EPID numbers, invariably, maybe they were not investigated and the likes, and they are not supposed to be counted as AEFIs. Now, we equally had issues with late submission. You see, on daily basis, they are supposed to submit the number of vaccinations, doses they have used to vaccinate these clients, and number of reported AEFIs. But of course, this data will not come out maybe up till 2 days, up to 1 week from some area councils, and it is not giving us what we want. We cannot analyze data and use it for action. Please, can you go on? So for me, for my next steps, I'm thinking we should arrange a clustered meeting with all AEFI surveillance actors in the state, like we've done before. We should repeat it, conduct AEFI data validation. So at the lower level, at area council or district level, we should sit down, look at all the data tools, look at all the reporting templates, and look at what has happened, who is reporting what. We should conduct daily, weekly, or monthly AEFI data harmonization. So on daily basis, before the vaccination site sends data to the LGA team, they should look at exactly what they have, look at what the surveillance officer in that site, if any, have, agree on what they are reporting, ensure that the data tools, for every case they say they have seen reported a case, there should be a case reporting form, and the line listing should capture that. We should continue state level data analysis for guided action. So for my references, I know this is just like a draft. I've not gone to the ideas engine to see materials that will support my work. Basically, what I use, what data we have at the state level, they call in data for FCT. I use the disease surveillance officers line listing. So that is what I have used basically, but I now still go into the idea engine to see what I can reference on. Thank you.
Okay, thank you very much. Yes, François.
No, thank you very much for these very nice presentations and very informative on your challenge, the reason for your challenge, and the action you're taking to address your objective. I think big congratulations. It's extremely interesting. And what maybe the only question I have is when you list your finding, which is like the cause of the challenge, you have listed the findings. I was, you know, when I say, when you say there is a LGA level AFI surveillance, do not harmonize their data before sending. Do you know why they don't do that? Is it because there is no mechanisms in place, or they work independently? What, according to you, is the problem of not harmonizing data before sending them to the state?
Okay, yes, thank you very much for this question. Now, basically, like when we noted this sometime in May last year, the very first meeting we held was to call all the vaccinators, COVID-19 vaccinators, we call the surveillance, and we agreed in that meeting that they are going to create a platform, a WhatsApp platform where all the key players will be. So the disease surveillance officer is on that WhatsApp platform. The vaccinators are on the WhatsApp platform. The routine immunization desk officer and the local government immunization officer will be on that WhatsApp platform. Whatever the vaccination team is sending to the routine immunization officer will be on that platform. So every person is seeing the data to refute or to agree. But we observed that that was not done. Now, if you say physically sitting together, because of the nature of job and because of the terrain we are, most times they will not be opportune to sit together physically to say, okay, this is the report going out. But where that is not done, we are expecting them to maybe communicate via any channel before sending the data out. So that is the one major challenge they have, sitting together on daily basis to look at the data before sending it out.
Excellent. Thank you very much for your explanation, because coordination in that regard, I know it's a very complex challenge between different units, and you're already addressing and understanding the key reasons, and you're trying to find solution for it. But thank you again very much for the work, the challenge you mentioned that makes sense, absolutely. And you're finding the reasons, the cause why you have this challenge, and starting looking at solutions based on the analysis of the specific cause. Thank you very much.
Thank you.
Okay, thank you so much, François and Joshua. There is Syed Miraban Shah, whose hand is raised. Over to you, Syed, and please do remind us who you are and where you're joining from.
Thank you, Charlotte. This is Dr. Syed Miraban Shah from Afghanistan, Technical Officer, WHO Country Office. Are you hearing me?
Yes.
Yes.
Okay. Thank you, Joshua, for the comprehensive situation analysis regarding AFI case documentation and recording. Actually, it is very important everywhere. Do you think that it is not reported by the healthcare provider because of termination? If they report such cases, they will be terminated by the authorities. In addition to that, most of the AFI cases are referring to doctors if they are sitting in public or private setting. Do you have any mechanism to coordinate it with the public and private doctors or providers? So they should be reported to you at the national or the district or provincial level. Thank you. Over.
All right, thank you very much. All right, for us in FCT, we already have an existing surveillance structure where the reporting comes from the facility to the district or local government level, from there to the state level. However, for this particular COVID-19 vaccination, on our vaccination cards, we have phone numbers of the DSNOs. That is to say, if AEFI is occurring after leaving the vaccination site, the client can pick his or her phone and call the number directly, and there will be a follow-up. Or the client can go back to the vaccination site and make the reporting. Where this is done, it is a responsibility of those persons in that facility or vaccination site, because they have the forms, AEFI reporting forms, to document and send such form to the next level. But if such a case is deemed to be a serious case, maybe it is life-threatening, it can lead to death and the likes, immediately they pick a call and put a call through to the state disease surveillance officer. So being not reporting AEFIs because they are scared, they'll be reminded. Of course, that is out of the question now. That is not the case for us here. Now, aside that too, we equally have AEFI focal persons in private and government facilities. Their major purpose of establishing these persons, about 25 facilities, is to ensure that whenever we have cases of serious AEFI, any facilities, we map our facilities to these focal points. They just call on them and repair our serious cases for them to investigate and manage for us. So all of this we have on ground in FCT. But like François said, one major challenge is maybe the coordination, which we need to look into. Thank you.
Thank you very much, Syed, and thank you again, Joshua. There is Professor Becky Tagbo, whose hand was also raised. Professor Becky, go ahead. You have the floor.
Thank you very much, Charlotte. Thank you, Joshua, for this great idea you are working on, a challenge that you're working on, very, very important. We are really concerned about safety of COVID-19 vaccines, and I'm happy at the details that you have shared with us. I want to commend you and your team. I just have 2 points to raise here. One is that sometimes, don't you think the problem is reporting tools, standardization of reporting tools? If all these different people who are coming up with varying numbers of AEFIs, do they have the same reporting tools? Is there the other one is that if there was an electronic database where everybody is feeding into, that will help to harmonize everything easily. And finally, on your key findings, if I understand the situation analysis format, the key finding is supposed to show your initial findings, you know, in answering your question, your challenge question. But the key findings you have listed here seem to be describing your problem. Instead of, after you have noted these problems, you did an initial investigation. What did you find? I think that is what that portion is asking for. So you may need to, you know, update it a little more or review it and bring up, you had this initial problem, which is the discrepancies, and then you went into some data sources to answer your question. What were the initial things you found as answers to your question? Thank you, and over.
Okay, thank you very much, Professor Becky Tagbo. Joshua E. Naomi, I don't know if you have any response to Professor Becky's questions.
All right, thank you, Professor Becky. So I've just picked to the point that is talking about standardization of reporting tools. Yes, we have standardized reporting tools being used. However, it is worthy of note that initially we had poor AEFI reporting as a state. Now IHVN came on board to see how they can support, improve on AEFI reporting. So when they came on board, what they did, they have a focal person that does not just wait for vaccinators or the disease surveillance officers to bring the reports, because that was a gap actually. So what he does is to visit vaccination sites from time to time and do active case search for AEFIs. When it gets these AEFIs, of course, it cannot report it. It's a partner. It's supposed to go through the normal channel of reporting from the local government to the state. That is where we find out that we have challenges, because for him, whatever he has seen now, with or without EPID numbers, at times he will say these are the number of cases. And we've actually addressed that, because whatever case he's saying is reporting, the DSNOs should be in the know and give it a number. So we are working on that as well. Now, the second thing is that for the electronic database, yes, we have our med safety, which is in custody of the NAFDAC. But of course, with med safety, it is supposed to be done by individuals. If I am done with my vaccination, I have any AEF, I have just go to the med safety app and do my reporting. But most persons don't go to that database to use it. And before COVID-19 vaccination, there was AEFI surveillance. So we are not distorting the already existing surveillance system. The med safety is just like to enhance what is already on ground. Now, concerning my key findings and whatever, I'll look at it and make necessary inputs. Thank you very much.
Thank you so much, Joshua Inomi, for your time, for taking out the time to share your situation analysis with us. And just maybe a quick question that will actually, I want to ask you, maybe that could help you as you review the key findings. And I see here you wrote out 5 questions that you seek to answer with your situation analysis. So I just wanted to ask you a quick question. Based on what you have found, are you able to answer all of those 5 questions?
Okay.
Based on your findings, are you able to answer these 5 questions?
Not really. I've not been able to answer question 5.
Okay, so that's great. So it's important, because at the level of key findings, also say what are the limitations? Are there any missing information? So it may be important as well to highlight that this is maybe some of the information you have not been able to get.
Okay.
Okay.
Thank you.
I see Prof. Becky, your hand is still raised. I'm sure you're able to unmute. Can you go ahead and do so?
Yeah, sorry, Charlotte. I just wanted to say that if I remember when Reda was describing this, he was saying that we may have several questions, but it will be advisable to address one. You know, I feel there are too many questions here.
Area of focus.
Thank you.
Yes, François, please go ahead.
Listen, I must say, well, I was not there at the presentation of Reda, but I feel that there are many whys here which will help to detect the various problems. The only thing is, if you look at the whys and the answer, maybe it's difficult to address all the cause of the situation that are the discrepancy situation. And you may, after, decide to choose which of those different findings are the most important you need to resolve to do better in this discrepancy. So I think your findings list, apart from the first one, list all your finding and your answer to those questions. But what you may be, it may be interesting for you is to find if you have to put your efforts in 2 or 3, in 1 or 2 causes, what would be the most important one that you want to address in your action plan? Because it's a lot here to address.
Exactly, François. And thank you so much. And Joshua, just to let you know that as long as the deadline has not yet reached, you can still go back and change. So you can still revise your situation analysis and resubmit it. So I hope you know how to do that.
But I just comment, Charlotte, I think it's just a step. That means for me, I was very interested to find all the cause of the discrepancies. What maybe there's only one part that could be benefit from structuring is to look at the weight of those causes and which one has the most important one that if addressed will make some difference, but not all the difference unless Joshua is able to address all those issues. But I'm not sure which one is the most responsible for the discrepancy of data. So just a
Can I
complement
say-
of information, because I'm really impressed by his analysis.
Yes, Joshua, please go ahead.
Well done. For me, you know, they say always ask why until you get to the root cause. That is why I have maybe more questions to answer, because I'm thinking by the time I'm looking at the causes, why, then I will be able to prioritize where to focus to get it right. That is the reason behind all of these questions. So maybe I will still work on it and get it better. Thank you.
Thank you
Yes,
very
thank
much.
you. Thank you too. Thank you too very much. And I see we have taken 30 minutes to actually dig into Joshua Iyinomi's situation analysis that we appreciate all. And you know, we always ask you if you want more. We always ask if you want more, and if you have already submitted your own situation analysis, if you want more, can you type more in the chat? And if you have already submitted your own situation analysis, can you raise your hand if you want to present your situation analysis? Right now, I'm inviting you, and can you type more in the chat if you want us to take one more situation analysis before we go? And then if you want it to be your own situation analysis. And I see Joshua Inomi is the first to say more, because of course she'll want to see what others have done. I see, okay, so please, if you have already submitted your own situation analysis, okay, I see Josephine Okide, your hand is raised. So Josephine, I'm going to invite you to unmute yourself. And it's, I think, okay, today it's still the Women's Month, the International Women's Month. So I think it's okay if we can get 2 women to present today. Okay, so Josephine Okide, are you able to share your screen, or will you want me to do it for you?
Oh, I thought you have it.
Yes, I have it.
Share,
okay,
okay,
if you want me to share, okay, I can do so. Please, can you start by introducing yourself while I dig out your situation analysis?
Oh, okay. Good day, colleagues. My name is Josephine Okide. I work for UNICEF in Maiduguri field office in the northeast of Nigeria. Thank you.
Okay, so give me a moment for me to get your situation analysis up on the screen. And you can just be situating us already on what's your situation, what's your challenge, what's your challenge and why is it important?
Okay, my challenge is on reaching 0 dose children in Borno State. We have so many children who have not received even 1 dose of immunization in their lives. There are so many of them in the northeast, especially in Borno State. And we all know that Borno State is one of the northeastern states that is affected by Boko Haram insurgency. So probably I read what I have here. Over 600 children below the age of 5 years, scattered in all 27 LGAs in Borno State, have not received 0 dose immunization. Over half of this number are in 7 LGAs. 3 LGAs are completely inaccessible due to protracted conflict, hence the challenge of reaching children in these 3 LGAs. Then, what strategies, that's my question, can we adopt to reach eligible children with 0 dose vaccination? How can we get access to the inaccessible locations and increase access in partially accessible locations so as to reach children with 0 dose and other relevant antigens? Are you moving, please? Yeah. So, just to explain who these 0 dose children are. Many children in Borno
are yet to receive vaccination against any of the vaccine preventable diseases. According to MIX 2021 reports, Borno State reached only 61% Penta 1 coverage, which is the 0 dose, according to Gavi. Then referencing DHIS2 to get immunization coverage for the local government areas, it was identified that about 20 out of the 27 LGs attend Penta 1 coverage of between 60 and 61%. And this is at 28 March 2022. But this is not the true picture, as there is serious challenge with denominator, that is population figure, which is the census figure of 2006 and does not reflect the population of the state in 2022. Out of the 27 LGAs, 4 LGAs attend less than 50% Penta 1 coverage, even with the wrong denominator. And 3 LGAs had 0% coverage. That is those inaccessible LGAs. This shows that no LGA is on track as for reaching 0 dose children in Borno State. This points to the fact that so many children under the age of 5 years are still left behind and are still prone to vaccine preventable diseases such as polio, measles, whooping cough, etc. Why do we have these 0 dose children? What are some of the reasons?
Josephine, okay. I'll just invite you just to summarize since we no longer have a lot of time.
Okay, the reason why we have 0 children, like 0 dose children, like I've mentioned earlier, we're in conflict. So many LGAs are inaccessible. Some are partially, some are very hard to reach. And there's a vaccine hesitancy issue. Sometimes this vaccination or immunization of children is not the priority of the caregivers. They have other priorities like farming work. And then I also noted that where there are these 0 dose children shows gross inequity in healthcare access. And then what have we done to reach these 0 dose children? We have employ so many strategies. We have what we call hit and run strategy, where we go through the military to go to those inaccessible areas to provide immunization. But doing this, we cannot reach everybody in a little window of opportunity that we have. And some other things, we have conducted outreach sessions. We have done integrated outreach sessions and so many other things we have done. And even after all these interventions, we're still missing out a lot of them, a lot of children. And my findings, after looking at all these things, I found out that the factors leading to this lack of access are many. They are complicated. And there are other hidden factors that I think we have not, especially as it relates to vaccine hesitancy, that people have not come out to say these are why they are refusing their children getting vaccinated. Some are related to cultural reasons, some are religious. And then, like I mentioned earlier, the issue of denominator is not really showing us the true picture of the coverage, because in some places you have the population figure of the census figure of 2006 does not portray the reality of today. And then micro planning is not really well done. So getting the actual number or baseline of the number of children in those areas are, and then the issue of the idea of, apart from the hit and run, what else can we do to reach these 0 dose children is one of the the major issues or major dilemma that we are dealing with. And coming to the specific actionable next steps, I said we will continue with intensive micro planning to make sure that we know the number of children we are targeting, and we intensify the hit and run strategy. We continue with the integrated outreach sessions, and then we can adjust our immunization coverages to reach out to those women who have other priorities during the day to make sure that we reach. And the use of data to ascertain where these missed children are concentrated, and then have teams to do vaccination exercises or sessions in how to reach communities. So these are some of the things I've been able to put down. I'm open to discussions and listening to everybody to learn more on how to deal with this issue, because it's really a very big problem. I read some of the postings from colleagues. I tried to extract some of these next steps from their submissions. So thank you, and I'm all ears to get some ideas to beef up my situation.
Thank you very much. Thank you so much, Josephine Okide, for that clear situation analysis. Before I turn towards Dr. François Gasse, I see there are some raised hands. So I'm going to invite Taban Milua. Your hand is raised for a while now, so can you go ahead and unmute yourself, Taban Milua, and start by reminding also who you are, where you're joining from, and ask your question or leave your comment concerning Josephine Okide's situation analysis. Over to you.
Yeah, thank you so much. Good evening, everyone. I'm not having a comment. I raised my hands to present after Josephine, actually. That was why I've raised my hand. Thank you.
Okay. Sorry, Taban. Can you join us on Thursday, so that on Thursday we'll start with your own situation analysis, because we are already out of time for today. Is that okay? Okay,
I think it's fine then.
All right, on Thursday then. Okay. So I'd like to listen to, since we listened to you, Syed, before, let's first of all go to Umar Garba, and then we are going to go to Syed Miraban Shah afterwards. So Umar Garba, can you unmute yourself? I'm asking you to unmute.
Thank you, Charlotte. Thank you, Josephine, for this wonderful presentation. I'm Umar Garba. I'm from Nigeria, in Kano State, supporting UNICEF. Josephine, this is a wonderful presentation, actually, and we have had all the challenges we mentioned. You know, these are some of the challenges in the Northeast, especially in Borno State. One concern I have is, I have heard about the strategy you put, but I know Borno is a issue with, is a place with this insecurity issue. How well do you think you can support also a kind of supportive supervision of the activities? Because zero dose is actually one of the major concerns, not even just in the Northeast, but in other parts of the nations also. But one thing we realize, there are two things I know that are contributing to zero dose. One, we used to have issue of the health workers' attitude. Despite there is a system that we used to put in place sometimes to track the newborn, especially where we have some community mobilizers or where we have some TBAs that are community-based. So linking them up with a facility, because our facility registers are settlement-based. So all the district heads and all these traditional institutions are linked with these TBAs and community mobilizers in such a way that once a bath is given, because one of the practice in the North is after 7 days of bath, a naming ceremony will be given. Why can't we use such strategies of tracking this newborn and then attending to these naming ceremonies and do this hit and run in the naming ceremonies houses. Thank you, and over. But it's a wonderful one, and I think it's highly commendable. Thank you very much. Over, Charlotte.
Thank you so much, Umar Garba. Before I turn towards Josephine, I would like us to listen to Syed. So, Josephine, if you can just keep in mind Umar Garba's question, concern, so that we'll hear Syed Miraban Shah. And if you're having connectivity issues, we are really sorry about that. Unfortunately, there's nothing we can do about it, and we understand your situation. But the recording of the session is going to be available later on Telegram and on learning.foundation. Over to you, Syed.
Thank you, Charlotte. Thank you, Josephine, for your situation analysis. And it is about the zero-dose children in missed pockets, or actually, it is because of the conflict situation and the state that which you mentioned. Did you implemented all the strategies that there is fixed outreach and mobile strategies for those areas? And it was allowed by the Boko Haram or not? And is there was an issue regarding the supply or demand side? So this is another point. And the third point, did you try this public-private engagement mechanism? So the private sector is working everywhere, and it is allowed by the any allies of governments. And did you try those private sectors to provide immunization services to those unreached or unimmunized children located in those conflict affected areas? Our thanks.
Okay, thanks, Syed. So over to you, Josephine. I'm asking you to unmute.
Okay, thank you so much, Omar and Syed. Let me start from the Syed's questions. Syed, all these strategies and all the strategies I mentioned were implemented everywhere except in those completely inaccessible areas. There are places we cannot go to. Nobody can enter there. Okay? So, of course, both the military and Boko Haram will not allow us to enter those inaccessible areas. And children are there. The children of other people, including the children of Boko Haram, they are there. We cannot reach them. So, and then for public-private partnership, all the private facilities are located only in the metropolitan LGA, which is the Meduguri, MMC, and Jerry. And there are only 3 or 4 private facilities in the whole state. So there are no private facilities here. Talk less of those inaccessible locations. Both the public and private facilities are not functioning. So that is for that. And then Omar, thank you so much for your suggestion for using the naming ceremonies and using the community mobilizers. Of course, the community mobilizers is our initiative. We are making use of them, but you know that they can only make referral when it comes to zero dose. Okay? Penta 1 is, they cannot do that if it was OPV. Of course, we can use the community mobilizers to implement that. So they do that. They identify, they register newborns, and they refer. But it is left for those people who are referred to take their children to the health facility to get vaccinated. But we will intensify that. I heard you right. We will intensify the use of naming ceremonies if they do that in those partially accessible and inaccessible locations, because those things also do not happen there. But where they happen, we will use those avenues to reach zero dose children. Thank you. And over. Hello, Charlotte. Over.
Dr. Ndayo, I'm asking you to unmute.
Thank you so much, Charlotte, the co-host, and everybody else. I'm so happy to have this opportunity, and I will be very brief. I appreciate the presenter, and I know she's speaking like somebody with very good knowledge of the immunization landscape. And I want to contribute to the determination of the denominator and calculations of also to remind us that it has come to a point that WHO had to inform states and having to miss any task. Specifically for every campaign, and though it's good to have a guiding denominator of population, target population, but it's also good to have in mind that the teams
Okay, we see, unfortunately, it's like we have lost Ndayo Ewart, so I hope he's able to get back on. But I'm going to turn now towards François Gasse. François, do you have any questions for Josephine Okide?
Thank you, Charlotte. First, I want to congratulate Josephine for being so specific on the zero dose. How many zero dose? Where are they? Who are they? Why they are not reached? I think a definition of the challenge, it's very well done, and a model of what, was so concrete. Of course, maybe Josephine benefited from the mixed survey, highlighted the problem with the DHIS, even if highlight poor coverage. And I think the cause, she analyzed the cause of the discrepancy as well between DHS and some cause of the problem with insecurity, outreach, accessibility, I think, and she highlighted some of the things, the strategy they tried and didn't get the success that she was expecting. Subline, it's the question I have, why have you eradicated polio, but she mentioned that using mobilizer and giving OPV was a key to the success. I have one comment at the end, because it's a very good, very concrete presentation, and it's a model. I wanted to know, do you have success stories in those areas before the insecurity, after the insecurity, or not? Are some other intervention being delivered, welcome by any means? I don't know how, but is there any success story in those areas, in some of those areas, and is there any lessons we can learn that why is this succeeding? Over to you. If a little comment, you have done a sero survey nationwide in Nigeria, and we found that 89% of women were protected against tetanus with an injectable vaccine. So I wonder why there's such a difference. Do you have any explanation?
Over to you, Josephine. François, unfortunately, I see Josephine is unmuted, but I'm not hearing her. Are you able to hear her?
No, I can't hear her.
Probably
on mute.
Yeah,
can you hear me?
Yes, we can hear you now.
Okay, I said maybe I need to do some homework and then come back to this issue during the next experience sharing. Yes, I know we did a lot of work on tetanus elimination, and some states, tetanus have been eliminated. So probably I need to do more work and then come back with full information during the next experience sharing.
Okay. Just we know from the surveys that even if 89% of women are protected against tetanus,
Yes.
We know that the lowest coverage, around 70%, was in the states that you're talking about. So
yes,
it was lower than the rest, but there's still 70%. So I wanted to understand how you did so well on that. Okay, thank you.
Yes, I'll come back to that, but I want you to know that the tetanus elimination in Nigeria is done phase by phase.
Yes.
Okay, so in some of those states where the elimination has taken place, those were the states that we focused on, and we did the max vaccination, and we made sure we reached all the women of childbearing age.
Yes.
So probably let me do some homework and come back to you so that I have the real information or full information of what I'm saying.
Thank you.
Yeah, thank you.
Thank you very much, Josephine. And François, I'm sure you don't have any further questions.
No.
Okay, great. So I think, and I see comments in the chat, really, I see Joseph Ngugi that asks, please give more on gender-based challenges as they play a major role. So Joseph Ngugi was asking Josephine if you could elaborate a little bit more on the gender-based challenges and maybe the role they play as far as the issue of reaching zero-dose children is concerned in your situation. Josephine, are you still there? Okay, maybe, yes, Josephine.
Okay, let me just say some few words on gender-based challenges. Of course, you know, in the Northeast, most women are in Poda and are not allowed to come out. That is one. Two is that a woman needs the permission of the husband to take a child for a vaccination. Even when the woman understands the importance of vaccination, that woman needs the permission of the husband to take child for immunization. And if the husband says no, that child remains unvaccinated. And sometimes it's not just the husband, it is the mother-in-law that dictates and says, I don't want this child to be vaccinated because of so reasons, and then that child remains unvaccinated. So women depends on the husband or the mother-in-law or the family to get children vaccinated. And then sometimes you see men, also in the same Northeast, you see men taking their children for vaccination. So these are some of the issues I can say about gender issues in immunization.
Okay, thank you so much, Josephine. It's really been a great experience sharing session today. We actually got to listen to two situation analysis coming from two different parts of Nigeria, from Joshua Naomi and Josephine Okide. And we hope that during Thursday's technical experience sharing session, we'll get to listen to more situation analysis. But at that time, if you are from Nigeria, please don't raise your hand so that we'll also get to see the situation in other areas and other contexts. Now, if you're having any issues, if you have not made progress with your situation analysis and you don't know how to go about it, I want to invite you tomorrow at 4:30 p.m. Geneva time for the technical support session. We'll be there to make the 30 minutes that we have together to count, meaning that by the end of the 30 minutes, you should have made progress as far as your situation analysis is concerned. So I've just shared the registration link into the chat. Please join us tomorrow, 4:30 p.m. Geneva time. If you're having any challenges with developing your situation analysis, and Dr. François Gasse and myself will be back on Thursday at 12 o'clock Geneva time for another experience sharing session. And we are going to start with, on that day, we are going to start with our peer that was not able to share his experience today. Okay, so thank you once again for being with us. Thank you for sharing your comments in the chat. Dr. François Gasse, thank you as always for being a guide on the side. Thanks to Josephine and Joshua for sharing their situation analysis with us. I'd like you to do one thing for me. If you're in front of your computer, just I'll do what I always do, ask you to unmute yourself in the short while. But I also want you to go to Telegram and tell us if you found this experience sharing session today useful and helpful. Tell us, say it in Telegram, and also invite others to join us on Thursday to share. So I'm asking everyone to unmute. If you're able to unmute yourself, please go ahead and do so, and put your hands together for our two sisters. That's Joshua Naomi and Josephine Okile, who shared their situation analysis today. And look forward to seeing you tomorrow for the technical support session, and on Thursday for another experience sharing session. Until then, wish you a great day, a great evening.
Bye. Thank
Depending on
you,
where you're joining us
Charlotte.
from.
Bye,
Bye for now.
bye, bye, bye.
So much.
Thank you. Bye.
We are grateful.
Yes.